From external speakers, we have our internal team giving you an update on the programme. So you'll hear from myself later as well, and also the Pathfinder sites who've been testing the work for us. So next slide, please. So my name is Ashley Hose, and I'm a Senior Improvement Advisor in the Mental Health Portfolio in Healthcare Improvement Scotland, and I've been leading on this work for the past sort of 18 months. Next slide, please. So hopefully everybody is quite familiar with MS Teams by now, but you have a chat function at the top. So everybody will have cameras off and microphones will be muted during the presentations. But if you wish to put any questions in or any comments, just use your chat function, which you'll see is number 1 there. And you've also got your more function, so you can use that for live captions and a live transcription of it as we go. And then of course there's the leave button, so hopefully you're all familiar with that. Next slide, please. So this webinar is now being recorded, and that's so that we can share the link with anybody who's unable to join us today, and they can listen to the session. So we just ask that you don't record it yourselves. And next slide. So just quickly, the agenda for today. So we're going to run through a quick intro from phase 1 of the programme of work that we've got, and then a bit from phase 2, which will be myself. And then we're going to hear from the Pathfinder sites. We've got somebody from Dumfries and Galloway and Tayside who are going to give an overview of how the programme of work has gone for them in the past sort of 18 months. And then hopefully we'll have about 10 minutes at the end for some Q&A for anybody who wants to pop anything in the chat box. And next slide, please. So I'm just going to hand over to our clinical lead for the programme, Dr. Susie Clark, who's played a huge part in this programme so far and is going to give you an overview of the phase 1 and the Scottish context of this programme. So over to you, Susie.
Hi everybody, I hope you can hear me okay. Thanks very much, Ashley. So at the risk of saying things I've already said before, I'm just going to give you a quick summary of EI. Next slide, please. So we know that psychosis is common. We know that Scotland doesn't provide very good care for people with psychosis at the moment in terms of access to all the evidence-based interventions that are helpful. We know that people with psychosis have increased risk of long-term mental ill health and physical ill health in terms of relapse, with high rates of suicide and treatment resistance and family distress and burden, and high levels of unemployment. And we only have 20% of Scotland having access to an EIP service at the moment. Next slide, please. So an early intervention for psychosis service is an integrated multidisciplinary team focusing on the young person and their individual needs to maximise recovery during what is a critical phase of development. So most psychosis occurs between the ages of 16 and 35, which is when people are becoming adults, making plans for their life or their employment, forming relationships, maybe leaving home. So these are all critical developmental stages that can be destabilised or derailed by psychosis. And so you need a service that specifically focuses on the stage the young person's at and supports their family to not just treat the psychosis and help them recover, but also get them back on their developmental pathway. EIP provides family interventions to improve carer well-being and reduces relapse. Its focus is to reduce the duration of untreated psychosis. We know that lots of people bounce around for a long time trying to access services. We know that we have high levels of young people on CAMHS waiting lists who have psychotic illness. And we know that people, if they have a long duration of untreated psychosis longer than 6 months, that significantly adversely affects their outcome. So we do need to try and pick up psychosis quickly and intervene early. People stay in contact with EIP services. We know that traditionally adult services particularly are not good at engaging young people, and they often are lost to follow-up. But we know that with EIP services, the majority of young people will stay engaged with the service. Now, some of that's to do with the model, which is about assertive outreach and offering the biopsychosocial treatments. So essentially, for early intervention to be effective, you need to engage people in the service. You need to give them a message of optimism, hope, and recovery. And only once you've done that have you got a platform to deliver interventions. We want people to get back to work, to go on to form relationships and so on. And that's the focus for recovery. Next slide, please. We know that EIP is the most effective evidence-based model of mental health care delivery that exists. And so it's important that it's prioritised. We know it's trauma-informed, it's cost-effective, connects people with community resources, can contribute to physical health parity because there generally is an emphasis on physical health monitoring and interventions. And also will provide resources to more marginalised groups. So one of the questions I often am challenged with is, why do you invest in psychosis? Why don't you just spread the resource among all of mental health services? And my answer is next slide, please. Psychosis is about levelling up. So basically, we know that if you've had 5 adverse childhood experiences, you're 193 times more likely to develop a psychotic illness. We know that people are more likely to develop psychosis if they're from Black and ethnic minority groups and deprived inner city areas. So investing in EIP is actually about levelling up disadvantage and investing in some of the most marginalised groups in society. Next slide, please. This table's from phase 1 of the programme, where we explored the needs of needs of different territorial boards across Scotland and what their needs would be to develop early intervention for psychosis services. And the EVIT team within HIS also reviewed the evidence base. So just to reiterate, engagement is a core component of EIP, particularly with a focus on recovery, that's developmentally sensitive, quite hopeful and optimistic, empowers people, engages with family, and is trauma-informed. In terms of what we deliver, we would provide biopsychosocial interventions with CBTP and other psychological interventions available, family interventions, low-dose medication and regular reviews and physical health reviews, support for carers, treatment of comorbidity, vocational support, and other practical support, for example, with housing. Ideally, you want a quick access to early treatment, so we would try and pick people up in esteem within 5 days, unless they're in hospital, and then it's within 48 hours. We would try and measure DUP. We try and have low caseloads, embrace diagnostic uncertainty. So at the beginning, diagnosis is not that reliable, so we probably use a generic diagnosis of first episode psychosis or psychosis non-organic type. Integrated multidisciplinary working. So that's the disciplines working together with the one caseload, not different disciplines sharing a community building, but not actually connecting with each other regarding patients. We have staff with ring-fence dedicated time. The service should last for 3 years and prioritises assertive outreach. And we also have peer support workers as a core discipline in the service. In terms of what's recommended, there's no evidence for augmenting CMHTs. It doesn't work if you try and deliver EIP in a CMHT. So we have a variety of different service models proposed for Scotland. The majority of the Central Belt probably needs specialist standalone teams, although this would need financed, obviously. The more dispersed populations may benefit from hub and spoke models, where you have an urban centre with a more dispersed rural population with spokes and local CMHTs, but those Those staff in the spokes are part of the EI team budgeted from the EI budget and linked to the EI team for supervision and line management. But they're housed in the CMHT to make sure they've got access to the local community connections. Or a bespoke model, which is really for a smaller service for a more dispersed population, maybe say less than 250,000, and needing to be a bit flexible in terms of responding to local needs. Next slide, please. So in phase one, the Scottish Government has prioritised EIP in the Mental Health Strategy 2017 to 2027, saying that all NHS boards should be delivering early intervention and psychosis services, which enable reliable delivery of the evidence-based interventions and minimise the duration of untreated psychosis. The Scottish Government then commissioned HIS, which to complete a needs assessment and review the evidence for rural models. A national lived experience reference groups was also started up to support this work and co-produced a report for phase one. And we're very glad to have our lived experience group continuing to contribute their advice to the next stages of the work. Next slide, please. I would like to just refer you to the website link at the end of the slides, which will take you through to the phase one and lived experience report. So in terms of the Scottish context, next slide, please. So the government estimated that about 1,400 people a year would experience their first episode of psychosis. There are 14 territorial boards in Scotland. Obviously, they're very different. We've got several island boards. There are some large inner city boards like Glasgow, and a mixed population or a mixed context for the delivery of EI, which can present challenges. Only NHS GG&C as an EI service for esteem. There are 5 to 6 boards in the central belts that are relatively urban, densely populated with poverty, drug use, ethnic minorities, and probably have a high enough incidence to need specialist teams. Other boards with more rural dispersed populations won't necessarily need a full-time specialist team, but might need some kind of hub and spoke or bespoke service. Obviously, there's a lot of consideration required about the local context. The low instance boards are likely to need education resources, access to supervision, and so on, but wouldn't have high numbers of psychosis probably every year. The needs assessment indicated that there was an appetite for EIP services, but there is a need for recurrent additional funding and training and flexibility in the model of service provision to take account of services that are already on the ground and priorities locally. I think that's me handing over to Ashley. I'm happy to take any questions. Thank you.
Thank you, Susie. Can I have the next slide, please? So I'm just going to give a quick run through of phase two, where we're at so far, building on the work that came from phase one. So next slide, please. So in 2021, the phase one work, there was money commissioned from the Scottish Government, and that was to establish 2 pathfinder services to test out what an EIP service would look like in the Scottish context, one being in that rural setting. So we've got Dumfries and Galloway, and we have Tayside in Dundee city centre just now, and they've been live since summer last year. And the work that we did with them to start off with was a lot of service design work. So there was, well, probably 6 to 8 months of work there, which was delayed slightly with COVID. And that was to help the services kind of establish their local implementation groups. So that was a multidisciplinary group of people coming together, some clinicians, some non-clinicians, some lived experience carers. And they formed that group to build what the service would look like before it actually went live. Susie has also mentioned there was a national lived experience group that had an invaluable role to a lot of this. And we also have an expert reference group, which meets quarterly, and that's a mix we have of clinicians, academics, Scottish Government, third sector, lived experience, and they continue to help guide and advise on the direction of the programme. As part of the programme, we also established the learning system, which is exactly what you're part of just now, these webinars where we're trying to use a wide platform with a bigger outreach so that we can get the message across about EI, so services that are happening in other places, such as Canada or Ireland, in England, and also how we can share that learning with other places and what we can pick up and learn in Scotland. The work has also developed key quality indicators. So there's no national measurement framework for anything on first episode psychosis. So we're tweaking that just now with the Pathfinder sites, and that will hopefully be ready by March next year so that we can roll that out and see if we can build on something nationally for some of that data. And there's also been the development of an Essentials of EIP Learning module. That's currently been put online with National Education for Scotland, hopefully due for rollout end of this year, start of next year. And it's a fantastic module that's partly been designed and delivered by lived experience, and that will be open to all staff across Scotland once that's on their module. Next slide, please. So this is just a quick overview of our learning system. So there was the learning sessions that we had for the test sites, and that was really crucial to get them set up and running to get to launch of their service. We have coaching sessions with them, so we meet every 6 weeks, where again they can share and learn from each other, but we also have some members of staff from the Esteem service in Glasgow, as well as our clinical leads. So that's been a really good place for them to learn and learn from each other. We have monthly newsletters which have been going out, although I think it's a mental health portfolio wide one now that we have. And we have a series of case studies, and these have been published on our webpage, which you'll actually get links to where you find the reports which are sitting in the chat box just now. And the case studies have been done on things like how to gather your baseline data, looking at assessments, looking at engaging with families and third sector. We've got a few more in the pipeline, so you'll be able to find them there. They're short, they're learning from the Pathfinder sites. They're very specific to what they've found and what they've learned, and a kind of a how-to guide. And then we have the learning, the national network events, which are these with our with our speakers. And we've had over 10 events and coming up to nearly 3,000 attendees and online views. So that just shows the want and the appetite for people to be hearing about the EI services. Next slide, please. So the data, the measurement plan was about a year in process, really being informed by the clinicians, academics, people with experience. So we now have quarterly data coming in from the Pathfinder sites, and there's 3 main ones we're looking at. We're looking at access data, so specifically the date the person's accepted onto the caseload or for extended assessment, and the Scottish Government have set that to be within 14 days. There's the date of the first symptom to the date of the first treatment, and then the percentage of engagement at the end of each month. We've got quality data, which is a fidelity tool. That's a separate piece, and that's come from the phase 1 work that Susie was talking about. And it's very important that when we're looking at these EI services that we maintain fidelity to the model. And so this model, it's sort of like a checklist, is something that we can go through with the Pathfinder sites to check where we're at with offering therapies, access, timely access, that kind of thing. And we're also looking at service user and carer feedback. And then we're looking at the outcome data. So that's the clinician and patient reported data. So that's like how many people are at still employment or education or training. And most of this data points will come in after about a year of somebody being in the EI service. So we're just almost coming up to that year point now for some of the people in the service. Next slide, please. So it won't surprise you that setting up a specialist service in the middle of COVID has had a lot of challenges. The diversity of the context, so we've got a lot of rural spots in Scotland. You can also have health boards that have an urban area and then a lot of rural around it. So we had to really look at how we would put an EI service into a board with that sort of context in mind and the challenges around that. There's also the bringing together of HSCP, so in larger boards, there might be 4 or 5 with competing or different priorities. So it's how you bring that together if you want to have a specialist service, which would be covering the whole board area. COVID-19 had a huge setback. It delayed the programme starting and the services launching, but it's also had a effect on workforce, as we all know. And none of these challenges that we've got here are specific to EI. They're wider NHS problems. We just happen to be hitting them as well in a specialist service. Lack of funding, it's always an issue. Scottish Government have had to make a lot of cuts, so we haven't had the funding that we hoped we might have. Nevertheless, we're trying to do what we can with what we have. There's a massive increase in demand for all mental health. People with psychosis don't often ask for help, so they're a population that we don't always know are out there. A lot of them are in the community and we don't know about them, and that's where these services have been really useful with their outreach. And then there's the other health-related targets, which are dictating priorities and time on staff, making it a bit more challenging to put in a service like this. Next slide, please. But regardless of the challenges, I think it's really important to point out that the pathfinder sites that we've had in Dumfries and Galloway and Tayside have worked incredibly hard to work around these challenges, which a lot of them won't disappear in a short space of time. So first of all, we're looking at prioritising the fidelity to the model and being consistent so that we are actually delivering an EI model, and then we're flexing that to the local need. So that's about being innovative. That's about testing different ways of working, which you'll hear about from the teams. So if we've not got a lot of access to psychiatry, where can we use nurse prescribers or clinical pharmacy? And where can we build a workforce that connects with existing services so that we already have links in with crisis or any other third sector ones that may help. There's the creating the EIP culture and ethos and leadership. So that's about the MDT working in this group and how all that functions together. And you'll hear a bit more about that from the teams. We continue to link with other countries for shared learning, and we also want to highlight the wins. So we've got some good recovery stories. We've got user journey mapping that we'll be able to produce quite soon for publication, and also looking at how we improve that interface working. So lots of solutions where there are some challenges. Next slide, please. So I'm just going to introduce you now to the Pathfinder site, and I think first on is Tayside. We've got Donna Petrie, who is the team lead at Tayside, and I will pass you over to Donna to give you an overview of how they've been getting on in the last year. Over to you, Donna.
Thanks, Ashley. Hopefully everybody can hear me, because I did have some technical problems earlier, but I hope they're all resolved now.
All good, Donna.
You can hear me, good. Just the next slide then, please. So just an overview of where we are with staffing at the moment. We have built up our staffing so that we've got 1.8 Band 6 mental health nurses in the team. We've got a consultant psychiatrist for a Friday morning session, and also an ST6 psychiatrist for a Friday morning session as well. So within that session, we have to try and combine everything to keep the fidelity of the model. So the MDT working, any formulation sessions, any patient reviews, and family care reviews. So we alternate them every week. We've got a full-time clinical psychologist, myself as a team leader, and I'm also a mental health nurse. We've got a full-time peer support worker, and an addition that was made later on as we started working was a healthcare support worker. So we recruited a healthcare support worker in May this year. Next slide, please, Andrew. So since we came into play last year, we have had 76 referrals in total. Out of the 76 people that we have assessed, we have supported 37 people. 8 of those people we've had on extended assessment. So being able to not just see a person for one time, but actually maybe see them over the course of 6 weeks has been really helpful to work out what's going on for that person, to find out if they are for the EI caseload or if they are signposted or referred elsewhere. At the moment, we have 20 people on the caseload plus 2 people on extended assessment. We've got 3 people that are having one-to-one clinical psychology support already, and another 2 that are due to start just once they've finished some work with their key workers. Next slide, please, Andrew. So the main challenges in setting up, as you've already heard Ashley and Nat speak about, has been recruitment. So having the right staff at the right time for the development of the service has been quite challenging at times. We did have to stop and cap the caseload for a little while just to make sure that we were providing an EI model of care, and then restart again once we had the right staff in place. With starting off with such a small team, it was quite challenging to keep people to specific roles within the team. Currently, the main challenges that we're facing is, although we are in a community care centre, getting clinic room and meeting rooms can be quite challenging. We do work across the different sites within Dundee, the community mental health teams, and the majority of our work is done either in patient homes or out in the community. So it tends to be psychology sessions and maybe our MDTs, and that we have to source rooms outside where we are. At the moment, we've still got a few vacant posts. So we have a vacant post for a medical secretary, an occupational therapist, and a consultant psychologist. So sometimes that means staff are slightly stepping outside of their roles just to make sure that we're meeting patient needs. Another challenge, as I just mentioned, is fitting in all those formulation and family meetings, because we have to do that all on a Friday morning to be able to have the multidisciplinary team input. Next slide, please. So although there's been a lot of challenges, there's been a lot of highlights as well. So we've slowly developed the service to reach the caseload that we have currently. We have managed, everybody that we have seen for assessment has been seen promptly and within the 14 days that's set by the Scottish Government. Anyone who's ready for clinical psychology input, can be directly referred straight into clinical psychology. There's no waiting list. The development of the family care review meetings is probably one of the highlights, that we've had a lot of good feedback from people we're working with and their families, and other people that have maybe not been within the team that have been working with the person that's been able to come to these meetings. A lot of good feedback about that, about the whole multidisciplinary team being around the table together, sharing the views with the person and the family and getting their views based on their care and any risk formulations as well. The multidisciplinary team input for formulations has been really good. And again, if there is anybody that's working with the person that's outside the team, we welcome their input as well. Having the peer support worker and the healthcare assistant, they're starting to plan some recovery activity groups, which we hope to get launched shortly. Next slide, please. Our peer workers already trained to facilitate RAP groups, so that's the Wellness Recovery Action Plan groups. Recovery is a core feature of the EI model, so to have that in place early on is really good and has been really beneficial. The first group's running at the moment. Professional meetings with other mental health services have went really well too, just to ensure that we're getting the right placement for people. So there was a particular CAMHS individual transitioning to adult services that we were able to work across services and work together to make sure that we've got the right placement for that person. Everyone that's on the caseload, there's been 100% engagement. And that has been promoted basically from the outreach work. We aren't slow, we're very quick. If somebody doesn't turn up for an appointment or meet us for an appointment, we're quite active in making sure we get in touch with them. We make sure we use that disengagement process quite promptly, and that worked out really well for one person, preventing a suicide in one case, that we were quite active in making sure we were going round to see the person. The enthusiasm of the staff to provide the best evidence care in line with the EI model is been one of the main highlights. Everyone is really, really focused on trying to do the best fidelity to the model that we can do with the resources that we've got, and that's been working really well so far. Next slide, please. So top tips to setting up a service. I think having some core clinical staff initially to make sure that you get the service set up from the ground, and ensuring that the role profiles are established early. That, as I said, could be easier said than done. If you've got a small team, the roles tend to overlap a little bit for a while. So with that, being prepared to think outside the box and make adaptations to overcome these challenges. For example, the staff and resources have been something where we've had to think outside the box quite a lot. We have now got some consultant psychiatry cover, but we link in very closely to the community mental health teams at the moment, to make sure that our patients have psychiatry cover. Change happens quite quickly as well, so being quite comfortable with change and being able to adapt quite quickly as things happen is a core component of the service. We started off very early, making links with all the third sector charitable organisations that are out there to make sure that we know of all the resources that are available within Dundee. And another aspect that we used was a soft launch, so we didn't just open up to everywhere all at once, so that we were sure we could cope with the demand. So we started off opening up to existing mental health services and the community mental health teams, and then gradually opened up our referral pathway to the stage that we're at just now, that we will accept referrals from anyone, self-referrals, third sector organisations, social work, etc. Next slide, please. And that's us. So I will hand back over to Ashley. If anyone's got any questions, though, please pop them in the box and I can respond to them. Thank you so much for listening.
Thank you so much, Donna, and thanks for giving us an overview from Tayside, who've been doing a fantastic job and still continuing to build the caseload. It's great. I think we've got Katie White to come in for Dumfries and Galloway.
Hello.
Thanks, Katie. I'll let you introduce yourself.
Thanks, Ashley. Hi, I'm Katie White. I'm consultant clinical psychologist in Dumfries and Galloway. For those of you who aren't familiar with Dumfries and Galloway, you really ought to come down because it's beautiful. But we're a really, really big region, geographically speaking. It's 6,000 square kilometres with a very sparsely distributed population. So we've got a population of about just under 150,000. So we cover from kind of Gretna right through to Stranraer. So it takes us about up to 2 hours to get from our base in Dumfries out west to Stranraer, where the next biggest kind of population is. Do you want to go to the next slide, please? So we've been tasked with trying to adapt the EIP model for this very rural population. And this is our current staffing. So there's myself. We've got David as our team lead. We have another key worker, which is Jamie. And And we have an assistant psychologist who provides wonderful support for us on the IT particularly. We have an occupational therapist half-time. Very recently, we have welcomed Laura to our team, who's a mental health pharmacist. We'll come on to really kind of how we're using her to support our service users. It's been very challenging for us to have psychiatry input, which I'm sure reflects something nationally, but particularly challenging in our area. And we are due to welcome a peer support worker to our team, which we're very excited about. Dumfries and Galloway have never had peer support worker role within mental health services, so it's really exciting to be able to kind of to trial this within our project, and hopefully it'll be something that'll be very useful for Dumfries and Galloway mental health services generally as well in the future. Our current caseloads, we have 22 service users active at the moment. We've had nearly 50 referrals, and just on the slide there you can see what's the kind of outcome of those referrals have been. We'll move on to the next slide. The main challenges that we've had in setting up an EI service here has been the rural population. As I've pointed out, there's a lot of kind of driving requirements. We cover, in Dumfries and Galloway, the way services are set up, we have 5 community mental health teams. So there's obviously a lot of interface with quite a few teams. As it worked out, actually, we were quite, in a way, it was a really good example, because the first few referrals that we got to our team represented every single community mental health team in Dumfries and Galloway. So from the get-go, we had to find a way in which to link in with everybody and be able to go out and see people in their community. So it's been a challenge, but one which I think we've managed to meet so far. On a pragmatic level, the key workers kind of divvy up the 2 kind of parts of the region so that they're not having to kind of cross across the whole region in one day. And that also means they've got more of an interface with smaller numbers of CMHTs. From a psychology point of view, I've been involved with people on my caseload from across the region, and I've had to use like Attend Anywhere, which has been quite useful for some service users, as well as going out to do clinics in other areas other than Dumfries. We've also had to identify and refine our kind of referral pathways. It was really helpful to be involved in the early developments of the service with support of Health Improvement Scotland to think about service pathways, linked in with local third sector organisations to think about what the main ways in which we can develop the service to suit the needs of the people that we were working with. I think the main highlights have been, I would say, and I'm sure my colleagues would vouch for this, we really feel that we work well together as a team. We've got a cohesive kind of team structure and a shared model for understanding of working with our service users. We work really hard to engage and work with families, and that's something we're all pretty passionate about. And we've been pretty flexible in the way that we've had to flex the service to suit the needs of our service users in the way that the challenges we face in Dumfries and Galloway but probably represent national challenges. And we were really delighted to win a Dumfries and Galloway poster competition where we got a trophy. I should have brought the trophy to show you all. So the main challenges have been, there's been a high, as one would expect with the population that we're working with, there has been a high level of comorbidity of substance misuse. So we've been having discussions with our local services that support people with substance use issues, as well as third sector organisations. We're in early development of materials, for instance, like kind of workbook materials on cannabis and impacts that has on psychosis. And working with people to think about reducing their cannabis. So that's been a really nice development. We've presented to networks of individuals who are working with service users with substance misuse. I know we've already touched on the issue with funding. That's obviously a challenge that everybody has, that we've had to face. We've not recruited everybody to roles straight away. There has, as the Tayside has touched on as well, we've had challenges recruiting to certain roles. And luckily, I think we've had people come to the oh yeah, somebody's asking a question about the key workers are nursing background. That's right. So we've kind of, in terms of the recruitment, there's been a bit of staging in that, so that the peer support worker role we're just recruiting to now, which I think would be a really good opportunity now that we've got some people that we've been supporting for a period of time. With psychiatry, it's been more of a challenge that we haven't had ring-fence psychiatry time. So what we've done is we've adopted a shared care model, which has worked quite well so far. It's been challenging in the respect that we haven't always been able to have psychiatry colleagues attend our team formulations, but we've made efforts to ensure that we communicate the kind of formulation and the support plan to our psychiatry colleagues, even if they haven't been part of the meeting where we've discussed it. But when we are referred somebody, we make sure that they are already open to the community mental health team, the respective community mental health team, which means that should they need to go back to that service, because after extended assessment they're not suitable for us, they have easy access to it. And even if they don't go back, they have the way our model of service works, they'll have access to psychiatry through our joint review appointments. But in the meantime, we've employed a mental health pharmacist who can provide us with some advice around medication, and be a kind of somebody that we could use as a point of contact for our service users to think about medication and side effect profiles. So that's an early development that we're really keen to make more use of. Next slide, please. It's just a wee slide showing us where some of our referrals have come from. There's probably a kind of equal number coming from, well, pretty much an equal number coming from inpatients and from primary care. I think in terms of the time frame of the work we've been doing since open to referrals in June last year, initially a lot of our referrals were coming from an inpatient setting. More laterally, we've been getting a lot more referrals from primary care, where obviously then we link them in with the community mental health team. And that gives you an indication of the kind of age range that we've been seeing in our service as well. Okay, next slide. And we've happily been able to meet the targets in terms of the first contact. Where there's been a slight wait, that's usually because of some reason that we can't be accounted for to do with availability, but we're mostly managing to see people within a week. And next slide. Our top tips are not unlike Donna's actually. I was really lucky to be involved in the development of EI from the very start, having put in the bid for Dumfries and Galway to be a pilot site. And I think it's been really helpful to be involved in that early service development so that we can start to think about how we might build up the service, who are the key people to be involved. We had a lot of our senior clinicians involved in those meetings too. So I think there was a real kind of buy-in to the model from the very beginning. We continue to place quite a high emphasis in our team on team building and ensuring that we've got a shared ethos. We spend a lot of time together, and I think that really can't be underestimated, the value of that. I'm sure you'll all agree that that's something that was compromised during COVID, and we're really keen that we don't do that again. We all try to be available and flexible, which you have to with this particular group of service users. And as Donna said as well, actually, just think out the box. When things are challenging, we try and think about how we can flex so that we can find a way to still use this model, which we're just fairly passionate about. And at the moment, we've been spending a bit more time really spreading the word now that we've got some data, now that we've got some good engagement with our service users, and we've got a group of individuals with lived experience locally that will be able to talk for how they think this model of service will be really helpful for other people in Dumfries and Galloway. So that's our next target, really, is going out there and spreading the word to the rest of the service. I think that's our last slide. Yep. I'll pass over to Ashley. Thank you.
Thank you so much, Katie. A lot in that as well. And I think what's coming out between both those presentations from the sites is that the strong teamwork and the passion of the people and the staff in the team, which has definitely created that strong engagement with service users, and really that ability to flex around the model. That's really crucial, I think, in something like this. We know what the fidelity is, we know what the core components are, and how do we flex around that to continue to make that work. Next slide, please. I just wanted to finish by just explaining what our next steps are. So this phase 2 programme is due to end in March 2023, 24. And we have EIP as an action in the delivery plan for the mental health and wellbeing strategy, which I think is out next month, the delivery plan. So EIP is definitely seen as a priority. Our hope is that we are going to put in a proposal into Scottish Government very soon. We would like to roll this programme out to other boards with our support. There will be some funding attached to it. It won't be recurring funding. It might be more like seed money, so something to help services get started, a bit like what we've seen in Dumfries and Galloway and Tayside, who are then going on to look at how they make this a sustainable service. We will be scaling up the training with National Education for Scotland, so they hold the training packages for the therapies, so that will be extended and offered out. We're working on a knowledge and skills framework as well for the wider system. And then we'll be looking at gathering that data I mentioned earlier and looking at developing consistent coding so that we're able to do that, as well as continuing to build this network. But our main hope is that we can look to other boards. So I guess my ask today is if anybody is interested in finding out more or interested in phase 3, please do get in touch because we'd be interested to speak to you and see how we could make that work. That concludes the presentation for today, but we did want to open up to any questions. Now, I don't think there's been any in the chat box, but if anybody does have any, feel free to either unmute or pop something in the chat box. We've still got Susie here and Katie. I think Donna has had to escape for an assessment to go and do. But I wonder, Susie, in the meantime, if you wanted to talk a little bit about, I think one of the biggest things, the challenges we've had around psychiatry is we're kind of looking at this as we're driving a bit more of a psychology-led approach to some of this work. So I guess how are we doing that better and how can we make that work?
Thanks, Ashley. I mean, I think the reality is that I think in an ideal world, you would have psychiatry involved with EIP services. I think most psychiatrists think they have a role with psychosis, but there is not enough psychiatrists to go around. And a lot of patients will get access to medication and they won't get access to the other evidence-based interventions. So psychology, we've got very low rates of delivering psychological therapies to people with psychosis in Scotland, notoriously badly compared to internationally. So I think something like 1% of people with psychosis have a psychological therapy in Scotland. The international figures are 25 to 30%, depending on whether you're looking at CBTP or BFT. So we are, as a country, not providing all the evidence-based care and treatment we should for people with psychosis, and we could do a lot better. Developing EIP services is one of the ways to do that. I think, as I say, we've been affected by the shortage of psychiatrists across the country, but we're ploughing on regardless, because it's important to try and improve what we offer young people with psychosis. So I'm very pleased to say that my psychology colleagues have very much established and shown an interest in leading in these teams and taking on the kind of psychologically informed care planning that's required with this young people, this group, to try and make sure they get access to all the evidence-based interventions and get them back on their developmental pathway. So we're recommending these are senior psychology posts. They're not for newly qualified staff, but experienced psychologists have got a lot to offer in this kind of integrated approach to patient care. Somebody made a comment about no social workers. So Esteem did have a social worker way back in the early days, who was really influential in terms of making sure that social circumstances and family carers' needs assessments and so on were considered. The reality is it's all about the money. Where's the money coming from? And the money's mostly coming from, certainly in Glasgow, it's health money. So and social workers were pulled out of specialist teams, so it's not something that but to be honest, in EIP services in England, so Southampton, I think it is a commissioned EIP service, so it's actually a third sector organisation that houses it, with sessional input from psychology and psychiatry, and many of the staff are social care staff. So there are different types of professionals involved in EIP. It depends a little bit on who's commissioning the service and where up here it tends to be health, so it's the mental health delivery plan and so on are board-wide responsibilities. And Katie's just put in a response about social workers working closely but not co-located. Thank you.
Thanks, Susie. If there's no other questions, then can we move to the next slide? We've just got a very quick poll to pop up just for an evaluation of today's webinar. It's going to pop up in the middle of the screen, so hopefully it'll be really easy for you just to click. Your names are not recorded for any of this. It's all anonymous. And I think there's 3 questions, so you can just flick through them. That just helps us give some feedback with these webinars. We've got speakers arranged for the next couple of months, certainly in November and January, so we'll be putting details out for that one soon. And finally, I think we've got a slide for contacts. Yeah, and a QR code there, getting fancy. So I think you can scan the QR code and it'll take you straight to the website, and that's where you will find all the reports. You'll find the case studies and an email address as well. So it's our main email address in the mental health portfolio. So any queries you have, any thoughts, anything you want to chat to us about, please just email that address and we'll be able to pick that up and come back to you. I really appreciate you all coming on to listen today, and I hope it was useful to find out where the programme is just now. As I say, we don't finish up till March next year, but it's useful just to give everybody an update and see how it's progressing as we're looking into phase 3. And I also want to thank the speakers, Susie, Katie and Donna, for coming along and giving those updates. I know Donna and Katie have got busy times in the clinics, as does Susie, so appreciate your time coming along and giving an overview of where you are with everything. And yeah, 5 minutes left. Thanks everybody for coming. Appreciate it all. Have a nice rest of the day.